we would have had respiratory depression because of effect of pethidine. So the antidote should be given immediately, intramuscular naloxone. Is the answer. All agree? And sorry. So the next question was a 5-year-old boy in the critical phase of DHF presented with so this child was given a 10 milliliters per kg bolus, and we usually expect only drop of 10%, but here there's a drop of around 13% drop. So that is definitely not due to the crystalloids. So that means the PCV drop is probably due to the blood loss. So because of that, pack cell should be transfused to discharge. So you want to discuss? Yeah, the third question was a 3-week-old neonate presents with tachypnea but no added lung signs and poor weight gain. What would be the most important immediate investigation on this patient? So neonate with tachypnea, highly likely to be due to respiratory in origin, but here we have mentioned that no added lung signs, but there's poor weight gain as well. So chest x-ray is out of answers. We can exclude chest x-ray because no lung signs. And so we are mainly suspecting a case of metabolic acidosis. The child has got failure to thrive as well as tachypnea without any lung signs. So the next important thing is to look at the pH. So the answer is arterial blood gas.
Question number 4. 1-year-old boy presenting with watery diarrhea was readmitted with persistence of watery stools 3 days after being discharged. He is febrile and otherwise well, with no significant findings on examination. What is the most appropriate step in his management? Now, this 1-year-old presenting with watery diarrhea, readmitted with persistence of watery stools 3 days after being discharged. So, other than watery diarrhea, there's nothing wrong. He's febrile and otherwise well, means he's playing, output is fine, everything seems to be fine. So, what is the most probable cause? It is going to be secondary lactose intolerance. So, continue breastfeeding and weaning food as usual. Arrange a stool culture as the underlying etiology may be a bacteria. Investigate for possible inflammatory causes. Start soy-based formula and stop breastfeeding. Reassure that it is a self-limiting condition. So what would be the answer? The answer is, the best answer would be E. You do not do any investigations. You do not do any stool cultures because the child is well. Investigate, there's no point investigating for inflammatory causes. Soy-based, we do not start because it's a self-limiting condition. So reassure that it will settle in another couple of days' time and that it is not a harmful condition. Okay.
Right. Sir, can we get as the answer A for this question because we have to continue breastfeeding?
Good question. I think these have not been scrutinized, so it is just a question. We will not put that sort of answers because number one may be also correct. So you can put it as correct as well because continue breastfeeding and weaning of food as usual. So we either will put A or E, but out of everything, E would be the best response. But I would say A also means the same thing in another way. So if you get you will not get this sort of answer because at the scrutiny, they will change either continue breastfeeding every other day and continue weaning food or something like that, and the answer will be either. Okay. So for the moment, you can get marks for A and E as well, right? Okay. Right. We go on for the next one. 5. A 5-year-old boy who is currently under chemotherapy at Cancer Institute Maharagama arrives to the OPD at a peripheral hospital with a temperature 40 centigrades. His full blood count results were as follows. White cell count is 1060, neutrophils 40, and lymphocytes 45, platelet count 145,000, HP 6.5. What would be the best option for this boy's management at the peripheral hospital? Now, what are we talking about here? Anybody? What is this condition?
Febrile neutropenia is the name.
Febrile neutropenia in a immunosuppressed child. Okay. So what are the answers? Immediately transfuse RBC. True, that's HB is low. Let's see the other answers. Transfuse GCSF. Take blood culture and start broad spectrum antibiotics. Transfer the patient to CIM immediately. Transfer the patient to a tertiary care center. It's the last one. So what would be the answer?
C.
Answer C. Yeah, that is the most important thing. In a febrile neutropenia in an immunodeficient patient, the most important thing will be to take a blood culture and start immediate broad spectrum antibiotics. You do not check whether this is viral or bacterial, because at this stage it is immaterial and you treat and then evaluate whether this is really needed or not. Okay, not in all patients, but in a patient with febrile neutropenia who is undergoing some immunosuppression.
The next one is a 6-week-old baby presents with stridor of 2-week duration. He was born at term following uneventful antenatal period with a birth weight of 3 kilos. His symptoms tend to worsen while crying and during feeding. He is comfortable in prone position. His current weight is 4.5. What is the most appropriate management option? So what are we talking here? Which condition? Anyone?
Can we get at the Pierre Robinson sequence?
Well, so this is, so we have not put anything to suggest Pierre-Robin sequence here. So here it's otherwise normal baby who is having stridor for 2 weeks and he's thriving very well. So
If you the striking, okay, it could be Pierre-Robin. What could suggest that this is unlikely to be Pierre-Robin with severe symptoms? What is the clue here in this the statements? We cannot see you, so anybody can answer. It doesn't really matter.
yeah.
Yes? Anybody? Why can't you say this is Pierre-Robin? It's pretty unlikely. Why is that?
He is having stridor since 2 weeks, not from the birth.
What do you think about the weight gain?
It's adequate.
Yeah. So if we are not thinking about Pierre-Robin, what this could be? What's the likely diagnosis here?
Gastroesophageal reflux.
Again, what symptoms are there for you to say that this is gastroesophageal reflux? What are the clinical features of a child with gastroesophageal reflux? There are two entities, reflux and reflux disease. Reflux is mainly vomiting. As somebody mentioned here, there's vomiting.
No.
No, sir.
So another condition that might present in a 6-week-old is stridor. What are the conditions that you know of? There are benign conditions, there are pathological conditions. If you go through the illustrated textbook, you have a whole table, no? It's stridor. You are sitting for the exam in March, no? Hello?
Are you doing professorial appointment these days? Hello? This is 37 better. Yeah, sure.
Can you hear us?
Yes.
So you are 37 batch, no?
Yeah.
Out. So
Okay, so definitely you would have heard this condition and you would have learned this condition. So here, if you go through the options, so some of the answers are aiming at different pathologies, differential diagnosis like nebulized with adrenaline. For what? Why do we do that?
condition do you nebulize with adrenaline? Come on, somebody. Which viral condition? Proof. Proof. Okay. Now refer to ENT surgeon. Or to the refer an ENT surgeon. Who is the most vulnerable or most dangerous thing that might present with the stridor? Not this patient. But
Acute epiglottitis.
acute. So is there anything to suggest acute epiglottitis in this patient? In this question number 6 history. You probably can see the history, no? At the moment. Can you see the history?
Yes.
Okay, so there's nothing to suggest any acute epiglottitis because the child is comfortable in prone position. So X-ray neck lateral is taken for what?
To exclude acute epiglottitis.
So ENT and X-ray neck lateral is mainly to exclude and to look after acute epiglottitis. Nebulized adrenaline for mainly for severe group. Start anti-reflux therapy. It is for gastroesophageal reflux disease, isn't it? Now we said there's nothing significant in this history to suggest like back arching, vomiting, that sort of symptoms are not there except for the crying. But it has mentioned that the symptoms has got worsened while crying rather than the child is crying always. The child is not crying always. This stridor has got worsened while crying. So what is the most probable benign condition that could be there in this child?
So this question would have come like, what is the most likely diagnosis as well? So here we have gone one step ahead and given the treatment modalities. So
I think the other way would have been easy. This is pretty.
Yeah.
You have to think two ways.
Yeah. So have you heard a condition called congenital laryngomalacia? Congenital laryngeal stridor. Yeah, that's the answer here, because we do have to intervene these children if they have problems with failure to thrive or apneic episodes or any worrying symptoms, but this child is otherwise growing well. So because of that, the management at this stage for congenital laryngeal stridor would be only the expected observations. Mainly we observe with the weight gain. Go to the next one.
The child presents with difficulty in defecation for last 6 months. We had passed meconium within the first 24 hours of birth. At the time of passing stools, he contracts gluteal muscles by stiffening the legs, and there is a history of streak of blood in stools occasionally. Abdominal examination revealed palpable fecal masses. What is the most likely diagnosis? Now, what does this mean by passing stools in the first 24 hours? What does the person who makes the question wants to include by saying this?
Hirschsprung.
Next one is cow's milk protein allergy. How would they present cow's milk protein allergy?
Director.
Yes.
So, cow's milk protein allergy. So, usually there's one feature which can be there in child with cow's milk protein allergy. So, little bit of stools in blood can be there, but here it's clearly says streak of blood. So, usually in cow's milk protein allergy, so they can have little bit of eczema, some maybe sometimes asthma. Yeah. So and also so mainly the loose stools or altered bowel habits rather than so here its history is very clear. Child is having some behavioral issues at the time of opening his bowel. That's why he does contracting gluteal muscles and stiffening legs. So highly likely this is functional constipation. Hypothyroidism is unlikely with the given history. And Crohn's disease, usually this is not the presentation. With this given background, this has to be functional constipation. Little bit of blood can be there even in functional constipation because the the rectal mucosa is very fragile. If you pass hard stools, what will happen? It can cause some tears to the rectal mucosa. That's the reason for them to have a little bit of blood in stools. So highly likely this child is having anal fissure as well.
And hypothyroidism would be pretty unlikely because all babies are strained, and by this time it would have been diagnosed with this case. So that's how answer number C is correct. Okay. Let's move on to the 8th. Acute lymphoblastic leukemia was confirmed in a 7-year-old boy who presented with generalized lymphadenopathy and hepatosplenomegaly. The hematological values were as follows: HB 7.8, white cell count 45,500, platelet count 52,000, blood urea 45. What is the most important step to follow before commencing chemotherapy? Now you can see what is the important things here. The HB is low, white cell count is very high. Okay, the platelet count is 52, blood urea is 45, which is a bit on the higher side. So what is the most important thing? Blood transfusion, platelet transfusion, colony stimulating factor, intravenous fluids and allopurinol, broad spectrum antibiotics. What is the answer that you have given?
D.
What? Which one? Which one? B.
D, sir.
And it is hemoglobin is low, platelet is again on the lower side. But the most important thing before chemotherapy would be D, because to prevent the renal complications of starting chemotherapy. Other things are also important, but the most important thing would be proper hydration. Okay, you probably have heard of hemolysis syndrome, and to prevent that, that is what you should do. Question number 9. A term asphyxiated newborn was given 5 infusion breaths immediately. He remained pale and floppy. He did not show any effects of respiration. Heart rate was 60. Chest expansion was not achieved. What is the next step of management? What is the answer?
Answer is 3.
Okay, let's go through. What has happened? Now, 5 inflation breaths not show any effects of respiration, but chest expansion not achieved. In that case, you have not opened the airways yet. So what is the next step? Next step would be repeat another inflation breaths, 5 inflation breaths, not that one. change over to ventilation. Ventilation, of course, you change over to ventilation breaths once you see chest expansion. Okay. So that answer is not there. Jaw thrust and repeat 5 inflation breaths is the correct answer. That's the second third airway opening maneuver. First one is stimulation and assess. Second one is 5 inflation breaths. Third one would be jaw thrust and 5 inflation breaths. Oropharyngeal airway and ventilation breaths, no. Ventilation breaths we discuss after seeing the chest expansion, which is not seen in this patient. Chest compression, anyway, it's not going to be an answer because chest compressions you do once you achieve the proper airway and chest expansion. Okay. So the answer is going to be an 8-year-old boy was brought in by the mother with 3 days history of fever. Mother is very worried that her child might be having dengue fever. What is the best investigation that can be done on day 2 of fever to find out whether this is dengue? Dengue specific IgM antibodies, dengue specific IgG antibodies, full blood count, ultrasound scan of abdomen, NS1 and T. I think this is a pretty easy and clear to you. What is the answer?
E. NS1
Why is it IG? Why is it not IgM? Because you check the antibodies after
5 days.
5 days. And it is again, if this case is a day 5 or 6 old fever, then you whether it is an acute infection or not. So IgM would be the answer if it is day 5 onwards. Done on day 5. The stem says it is done on day 5 onwards. Okay. Full blood count ultrasound is not going to confirm that it is dengue, but it will be helpful. So they are not going to be answers. Right. So remember, within the first 5 days, it is going to be NS1, and after 5 days, it is going to be dengue specific IgA. Question number 11. A 4-year-old boy is on treatment for encephalitis and was on intravenous fluid for the last 4 days. He started taking few amounts of oral fluids during the last 18 hours. Bladder scan revealed only 10 ml of urine in the bladder. What is the most important investigation that you would do to arrive at a diagnosis? Answer?
E.
So why is that? Now what is the most probable diagnosis? Yeah, most probable diagnosis is SAIDH. Why is it SAIDH? Why has it become SAIDH? Because this child has been on IV fluids for the last 4 days, and he has started taking few amounts of fluid, oral fluid as well. So he is on maintenance IV, plus he is on some oral as well. So he is overhydrated, and that can cause what you call SAIDH, especially in patients with CNS infections. So that is what the stem says. So if you want to confirm what exactly why he has not passed urine, you should confirm that this is SAIDH. And to confirm SAIDH, you all know that the important thing is to find out whether the serum and urine osmolality, what the figures are. And you would expect a very high serum, very high urine osmolality, and a very low serum osmolality. Okay, so the answer is going to be E. Number 12. A 5-year-old boy presents to the emergency department with moderate dehydration, with acute gastroenteritis and severe vomiting after failed oral rehydration. A 5-year-old boy presents to the emergency department with moderate dehydration, with acute gastroenteritis and severe vomiting after failed oral rehydration. What type of intravenous fluid would you commence on this patient initially? What is the answer?
Answer
So it is normal saline. So most of the dehydrations you would rehydrate with normal saline, and most of the cases, not only in this thing, but whatever it is, what would you give in a patient with dehydration with DKA? It's going to be normal saline. So if you can't remember, the most probable answer is going to be normal saline. So all the other answers are incorrect. Would not be the best answer. It is going to be normal saline. Okay. Question number 13. A 14-day-old child presents to the pediatric ward with very high TSH, more than 100 international units per deciliter. Report, TSH report on the newborn screening. What is the next step in the management? Repeat TSH on the whole blood sample. Reconfirm the findings with a dried blood sample of TSH. Do an ultrasound scan of the neck. Perform serum TSH and T4. Start levothyroxine immediately.
Answer is DS. TSH is more than 40. So we have to do serum TSH.
Yeah. You have to confirm reconfirm, because this is not a confirmatory diagnosis. This is a screening that somebody has done. Screening does not mean it is always the disease, but you cannot delay the management as well. So you know that T4 TSH can be done within hours, and you see the report and you start treatment on the same day. But the important thing would be to confirm it itself, because this is a screening thing. You want to confirm and start thyroxine immediately if the TSH and T4 also suggestive of hypothyroidism. Okay, so the immediate one would be TSH and T4, but we would not delay starting levothyroxine if these results also suggestive of hypothyroidism, where you would get another high TSH and a low T4. Okay. Question number 14. A child with a history of asthma presented with severe difficulty in breathing, respiratory rate of 48 minutes, intercostal and subcostal recessions in bilateral bronchi. Oxygen saturation was 91%. First step in the immediate management is administer oxygen, do back-to-back nebulizations with salbutamol, nebulize with ipratropium bromide, give intravenous hydrocortisone, administer intravenous salbutamol. What could be the answer?
A.
Answer A. Because the most important thing would be give oxygen, which you can do immediately. To nebulize, you will have to put things inside and get prepared. So as soon as the patient comes, what do? You do give oxygen through a face mask. Okay. So rest of the things are also correct. Nebulize with ipratropium, this takes time. Give intravenous hydrocortisone, yes, true, but it takes time. Administer intravenous salbutamol, that's the second line drugs, not immediate drugs. Okay. On to the last one. A 4-year-old child presented with high fever and abrupt onset of stridor. On examination, he was ill looking and had a soft stridor. He was given oxygen via face mask. What is the next step in the management? Nebulize with adrenaline, nebulize with budesonide, start IV cefotaxime, all for help to secure airway, give intravenous dexamethasone. What would be the answer? Now, hopefully you could get the answer from the previous MCQs. What is this? What is the condition?
Acute epiglottitis.
Acute epiglottitis. So what would be the answer?
D.
D. Why nebulize with adrenaline? That is mainly for flu. Budesonide, yes, but not in this acute stage. When you nebulize, the child will get more agitated and things will get worse. Start IV cefotaxime, yes, you should start broad spectrum antibiotics, but once you secure the airway, because if you start putting a cannula, the child will again agitate and things will get worse. So the answer is call for help to secure airway, mainly the ENT and the anesthetic team. Give intravenous dexamethasone, yes, you can give, but not at this stage. All IV things should be done after securing the airway. So the answer is going to be D. Okay. So that is it for today. Now you can write your comments with the changes that you want to have. Take 20 SPRs. I think get about 30 SPRs in your MCQ paper. So if you really want, we can go on for 30 or we can finish at 15. 15 I thought would be cover an hour rather than going on for a long time. Whatever you wish, you can write in the the comments so that we can go through them and see. Hopefully we'll do something again, not next Monday, maybe next Friday, because we'll have to go through your comments and see the changes and see how it goes. Would you like to continue this sort of thing, or you think it's not that really worthwhile?
Yes, sir, we would like to continue.
Okay. So you probably can, each of you can see how many marks you have got, no? From your assessments?
Yes, sir.
But I cannot see how many marks each and every of you have taken individually, but I could see how the batch has performed in each and every question, and as a group for the whole 15 questions as well. So we have an objective assessment to see whether you as a group, whether you are improving or not. So the whole idea is to improve yourself to the maximum before you sit for the final year common MCQ. What we might do is we might not use any MCQs from our banks, but we will use MCQs from what you have given us, your banks. So you can give us MCQs from whatever you papers you have. We will go through those things and correct the MCQs and get the MCQs here, as well as from some of our MCQs as well. Okay. So please, during the weekend, go to the LMS and go through the feedback, not a form. You can write whatever in the feedback area that will be seen soon, and hopefully see you next week. Okay. And when you start the next week, we'll give you a feedback on how your group has performed, so that you will also get an idea what exactly the group and what questions were difficult for you. Okay. Right. So we'll stop there. Okay. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.